going to enter another level. Yesterday, if you remember, we ended the day with the segmentation of the carotid system. So we still stick with the segmental arrangement, which we know for sure that the very easy to see is the spinal segment. So, and yesterday you see some of the carotid segment. So we are now talking about the junction in between the cranium and the spine, which is the vertebrobasilar segment. The usual diagram here, just to remind you that we are dealing with the dorsal and ventral aorta and these first, second, third aortic arch that has the connection with the two artery at the near midline, which is the ventral longitudinal neural artery. The connection there is for sure hypoglossal, pro-atlantal 1, pro-atlantal, and C3 cervical segment. And that is the area that we are talking today. So the start by the fusion of this ventral longitudinal neural artery, and actually more paramedian there is another lateral neural artery also. So the midline fusion of these in the spinal level, you will have the ventral spinal artery or anterior spinal artery. And in the cranial part, you will have the basilar artery with the same type of midline fusion. So there's some regression of the artery occur at the hypoglossal artery, the future as an inferential artery, and the pro-atlantal 1, 2 will have the connection to be the occipital artery, which some regression and variation will be seen soon. So that's what we see. And then the flow makes some involvement. Because at the beginning, you know, all this posterior circulation relies mostly entirely from the blood supply, from the anterior circulation through all this connection of the carotid vertebrobasilar anastomosis. Subsequently, the posterior fossa structure grows, including the occipital lobe. So the posterior circulation becomes progressively independent from the anterior circulation. And usually in the adult, we are left with only the PCOM. And then later on, the intersegmental artery occurred to becoming a vertebral artery, connected at the C7 level with the subclavian, the way that we see yesterday. So concerning this type of metamass and the arterial pattern, you see that each segment you have right and left segmental artery. And usually there is a vertical connection, vertical anastomosis between each segment. And then it starts to fuse at the midline. It starts to fuse at the midline for sure, later on becoming this type of single artery at the ventral aspect of the midline. Some of the segmental artery regress for sure, and left with the dominant one that we can still see in the adult, which is radiculomedullary artery. And so you know that there can be many radiculomedullary artery contribute to this midline ventral artery that supply the segment. So the roles of segmental or metameric arteries are supplying the skin, muscle, bones, follow and supply the peripheral nervous system, and they supply the central nervous system. In posterior fossa and cervical level, segmental artery is equivalent to, as the diagram previously seen, radiculomedullary artery of posterior fossa. and sure it can replace the just fusion of vertebral artery or basilar artery. There are examples of the function of these metabolic arteries in some disease called COPS, SAMS, or CAMS. In the spinal level, spinal arteriovenous metabolic syndrome can be seen, and at the junction of cranial to spinal level, you can have SAMS 1. That means at the level 1 of the segmental artery, you can have, see here, the skin is a cutaneous malformation, and you have the muscles and soft tissue malformation, and you can have intradural malformation. For sure, at that segment, the intradural malformation will be the AVMs of the medulla oblongata. This is, for example, the full spectrum of the metabolic function. So, the true segmental artery versus the intersegmental anastomosis. You know that from C1 to C7, we have each segmental artery, which actually the horizontal part of vertebral artery is the true segmental artery because it keeps still the shape and the direction of the true segmental artery. While usually in adult, all the rest of segmental artery regress. And the intersegmental anastomosis occur and become big is called vertebral artery. So vertebral artery is just the vertical intersegmental connection between all of these important segmental artery there. In the lower down from the cervical segment, for example, upper thoracic segment, you can have the same vertical intersegmental connection called suprametapostal artery. When you hook your catheter into to see the T1 to T4 segmental artery, usually you select the suprametapostal and you selecting the vertical intersegmental anastomosis. And the lowmost part of this example of vertical intersegmental connection are called lateral sacral artery. If you hook into that level, you can see all tiny little segmental artery, and the truth of the vertical anastomosis was seen there. Not only that, there are still more of the spinal cephalic homologs, especially we talk about perforators. You know that in the spinal level, you have this kind of ventral penetrated perforators, very important one that we call sulcocommissural arteries. And supply to of these perforators are centrifugal type, whereas the surrounding circumferential or what we call dorsal type of perforators. For example, in the spinal level, example of radiculopyral artery, that it will supply from outside in or centripetal type of entrance of these perforators. Same thing occurred in the cranial spinal level. If you have the ventral perforators perforate in the same type of direction, and all these dorsal or circumferential perforators that will supply the rest of the neural tissue. This is a nicely dissection. Let's see this ventral spinal artery give rise to the ventral type of perforators, while the dorsal system give rise to kind of network and entry the area of the neural tissue. Nice dissection will be shown more by Philip. So talking about this arterial embryology, we can talk that we have approximately 31 segment minus plus, okay, from the head neck down to the end of the segmental level. So we are talking now from C4, 3 to 1. At the C1, the nerve regress. And then up to the hypoglossal, where we have the cranial nerve 19, part of 11 and 12. And then above that, the aortic or the eighth cranial nerve not going out of the cranial cavity that Pierre was putting in the book. And the uppermost part of the region we are talking is the trigeminal level. So by knowing that, we can draw this very interesting diagram. We know that there is midline, longitudinal neural artery, and then we are talking from the C1, equivalent of pro-atlantal 1, pro-atlantal 2, C3 arterial segment. Above the C1 is hypoglossal, above that is aortic, and the trigeminal at the end of the region. And we can draw the pyramidal line, which we know that there is a cranial nerve 11 following the line. So at the trigeminal level, it becomes internal carotid basilar anastomosis. And the aortic, it's IGA. At the hypoglossal is asympharyngeal pica level. At C1 occipital vertebral artery, we show you that there is a segment of the vertebral artery by that level. And down to C3 and C4, we are talking about ascending cervical artery. We can know that in the midline fusion, this midline pair artery will become in basilar artery or the ventral spinal artery down. And we can draw the dura to make sure that we are describing proper thing. And then in the very classic symmetrical arrangement, this is going to happen that you have very symmetrical origin of everything, IGA, PIGA, down to all the segmental artery. I will download this diagram to you later on at the computer outside. So by having this diagram, you can explain all the variation of the region. I will ask you if you have angiogram. You don't know how to describe it. The first point is to see which vessel you know. For sure, you know vertebral artery. You know that is horizontal segment of vertebral artery, and you know pica, for sure. So the rest is that what happened, what gives rise to this. So that means if you try to see that it depends on the regression and the flow of the remnant of the segmental artery. This for sure you mark yourself C1 segment, 2, 3, 4. It's about at the 3C, 4 segment, you have higher flow coming and filling up all these pica, vertebral artery and basilar artery. So that means the usual vertebral artery may become a little bit small or plastic type of thing. So you know that if you have, again, you don't see down the vertebral artery, you see from the C1, 2, 3 level up, and you have the high flow coming from this artery, getting hooked into the C3 segment and filling up this. So at the C3, 4 space, you can see this ascending cervical artery filling up this. What about this? You know that mostly is a vertebral artery and basilar artery, and this is pica for sure. But what about this? So you can use a diagram to make sure that now you're having a little bit down outside the dura, the pica here, a little bit outside, and you have some flow filling up from C4 segment, filling the vertebral artery, whereas the remnant of the usual vertebral artery are small. So the relationship between occipital and vertebral artery again will be a stage. We are talking, remember, pro-atlantal 1 and pro-atlantal 2, the future connection becoming this occipital artery. Okay, so there is no surprise when you see that injection of vertebral artery, you can see easily the occipital artery. And even in this case, you see bilateral occipital artery coming from the vertebral artery injection using the C1 and on the left side C1, C2, which is explained easily by all these embryological things, that there is a persistence of the channel as C1 and C2, which is the pro-atlantal 1, 2. So it can be big, this big channel can be big, giving rise to this. So there are many names when people try to explain the anatomical variation. For example, this injection you can call the basilar system originate from internal carotid artery. Cervical segment join posterior fossa via C1 space. And you can see also the pro-atlantal, you can name pro-atlantal one origin of occipital artery. You can, whatever you can choose to name depending on what you want to state in the same angiographic injection. Depends on how the meaning, same meaning, you know what you are doing. So when we draw the diagram, for sure at C1 segment you have higher flow persistent filling up the system, and most of the time the rest of the normal pathway are small. C2, same. You can use this C2 segment to fill in, you know, this is vertebral artery, this is C1 segment of the vertebral artery, and this is pharyngeal occipital injection. You see that in the this occipital coming down to the C2 channel and filling up. So again, the name can be the basilar artery originate from this occipital artery via C2 space. And some can use a muscular branch via the C2 segment to filling up all these anastomosis. In the real example, when you inject this external, so-called external carotid artery, this is no surprise that giving this occipital artery filling C1 space, also filling via C2 space, filling up all the vertebral basilar system. And this is again this occipital artery coming down. It's not at that level, it's coming down to the point of C2 filling up this pica. So by drawing that, you can have nice high flow at the C2 level, filling up the pica, and also later on filling up the vertebral basilar system. In the clinical usage, we would, for example, have this high flow fistula at the right C1 segment of the vertebral artery. You have AP of the left injection and you have lateral view of the right injection. So by knowing that the artery of the region must be at least pharyngeal occipital artery, so the artery will fill easily the sumbing of high flotation using all the channels that are available. You will see better where are the true shunt, and this is after knowing the true shunt, you put a single detachable balloons, and this is the result. And another clinical case, you are injecting this vertebral artery, lateral view. At the C2 segment, you are filling up this pharyngeal brush, or as a branch of asinopharyngeal for sure. While you inject this external carotid and you see this occipital artery at the C2 level, same artery filling up all these vertebral system. So this is everyday cases that you go back and you now understand what you should be worried when you treat any disease related to this variation. Again, the C2, C3 level, you have this nicely see the occipital artery coming up. When you inject this pharyngeal occipital, you see the same channel filling up the vertebral artery there. So we are skipping from the occipital artery now to the hypoglossal or future asinopharyngeal artery. Asinopharyngeal artery is a very interesting artery because it's probably the only artery that supplies the GI system, which is pharyngeal branches, and the neuromeningeal trunk, which is the neural system. So it's very interesting, even it's a very tiny little artery. Nowadays, I would highly recommend if you are dealing with the disease related to acid-pharyngeal to do very super selective injection, putting your diagnostic catheter properly in the acid-pharyngeal, not global injection, so that you will see much better all this. So the diagram, you know, all these branch, the musculospinal branch, the very frequent branch to supply the hypovascular tumor, for example, glomus tumor of the region. When it persists, it can persist big, or it can be tiny little remnant. And this is the large and small persistent hypoglossal artery. So what are the hypoglossal persistent artery in the diagram? You know that at the level of so-called hypoglossal level, the higher flow persists and filling up all the system, that you can draw the diagram there. And for sure, the rest of the system could be small hypoplastic. You can see nicely in the non-invasive imaging also the possibility of hypoglossal persistent. And on the right side, this is example of both filling from the of the pica, one from the usual origin of the vertebral base artery and one through the hypoglossal remnant filling up. And you still see the tiny little twig of remnant of this by arterial supply to the pica in this case. Another most important connection is the acid-pharyngeal to vertebral artery. This is another diagram I highly recommend you to go into the book of the surgical neuroangiography and study. You will see more and more of the value of this diagram that Pierre draw. And for example, you see now all the important connection between acid-pharyngeal for sure. The pharyngeal branch over there is hypoglossal through the hypoglossal canal. You will see that it's coming down C1, C2, C3. C3 is a very important marker. It always hooks many arteries. For example, D is hypoglossal down to the vertebral artery. Number 8 is vertebral artery. Why in the occipital system you have this possibility of having the cervical artery hook also into mostly C3 level. Contribution also possible from the acid cervical. So with this diagram, you can see a lot of explanation. For example, this is the case that you inject the mostly the occipital artery. What you see now is that you see that this is from occipital artery using the C3 channel fill up vertebral artery. You see exactly same curve here, and even the same track is seen in the vertebral injection. Okay, why a tiny little hypoglossal branch coming and filling up at the same point? So it's tiny. It will be seen in all your regular type of daily work. Be careful that you are embolizing occipital artery. No way that you can have stroke. So think about it. I was going to embolize this glomus tympanicum. Paraganglioma or glomus tumors are very good example of acid-pharyngeal study. If you want to study all branches and anastomosis of acid-pharyngeal, go for your case of glomus tumors. But please do the super selective injection. By having this acid-pharyngeal AP and lateral view, you see a juicy, nicely hypovascular mass. Be careful because we know that anastomosis are there. Even this, you were able to embolize nicely. After embolize, you see nicely this hypoglossal coming down to the C2, C3 segment, filling up this vertebral artery. And if you don't realize, it will be a bit too late. So make sure that you are distal enough, no much reflux in anything, and you know that the possibility of the anastomosis are there. I'm going to introduce you to extradural artery, named the extradural artery, because it's a very nice connection between the branch coming down, hypoglossal branch coming down from the asinopharyngeal, and meet with the branch coming up from C3 segment, making a nice loop around the dens. So it's called odontoid arch system because it's bilateral contribution of both the descending branch of hypoglossal branch and branch from the C3 vertebral artery. And it's extradural, make sure. So that means if you see in the vertebral and asinopharyngeal injection, in the vertebral injection, you mark yourself for this anterior spinal artery, okay? So you see a contribution down, and there is this artery hooking into the C3 portion of vertebral artery. Again, with this ascending pharyngeal injection, contribution coming, hooking down into the C3 segment. So that means in AP world, it's easier because the shape are very classic for dens. In this, you can see nicely, for example, this injection of the asinopharyngeal showing the contribution, the full arch system evenly flux into contralateral contribution from the contralateral asinopharyngeal artery, and this vertebral artery for sure. I was doing this glomus tumor again for this embolization. You see, it can be tiny little filling up of the filling and then refract into the contribution from the contralateral asinopharyngeal. In clinical usage, as I said, it's dural, for sure, extradural artery. So it will function, or it will be bigger, or it will supply mostly the dural disease. If it starts with the meningioma, it's a dural disease, so you can nicely see it become larger and taking a part of the supply to the tumor. These vertebral artery injection are strange. It ended at the area of tumor, and it's have this pica supply. Unfortunately, the pica is bimetric supply, so it means try not to touch or destroy it because you're going to have bilateral symptoms. Okay, so by doing that, what else you see? You see this nicely curved of hypoglossal branch of the ascending pharyngeal artery. So in the injection of the ascending pharyngeal artery, exactly same curve as seen supplying the tumor. So you have now more choice if you need to go for the treatment or embolization of this. As well as the dural shunt at the region. If you have dural arteriovenous fistula of the area from the foramen magnum C1 area, for sure you have the dural artery coming up. Don't forget that you have this nice artery that become enlarged and be part of the supply to the region. In some special occasion, you may be able to use it. Protection of the vertebral artery, use it to fill up the shunt endovascularly, and it can be one of the choice. So in the foramen magnum level, you have all the possibility of supply from the Cliven branch, the hypoglossal branch, blood branch, area of this depending on the anterior lateral posterior part, including the possibility of the forks of the region. So by diagram, you see all this possibility of supply around the foramen magnum by the branch, mainly asinopharyngeal. Example of the clinical usage, we were having this congested myelopathy and abnormal vessels, and you inject vertebral artery. For sure, you see abnormal veins. There must be a shunt. Immediately inject what? Asinopharyngeal oxygen injection. You will see much better lateral view, AP view, where it is exactly crossing the hypoglossal canal and open into the veins. Now you see all this change of the caliber open into the veins. So now you have much better see where is the true shunt, and you can choose which pathway you are going to treat. So what about the acid pharyngeal and connection to the internal carotid artery? This is a very useful diagram again in Pierre's book. It's Pierre Bernstein and Tarouche, who is sitting at the end. He's showing you the picture of the book later on. So I'm saying that this pharyngeal artery have a high potential of connected into whatever the thoracovaginal branch or the palatine, whatever, and then it can also finally have the connection to this IoT to the internal carotid artery. Whereas for sure the neuromeningeal trunk is said a lot that there are many pathways to have anastomosis, including all the lateral clival or pathway to hook into the carotid artery. So when we talking about mainly the intratemporal carotid anastomosis, you will know that we talk about this name of the branch. For example, the mandibular artery, which is for sure the remnant of the first aortic arch, the cariotympanic, the meningohypophyseal, the ILT trunk that was there, and it can be nicely drawn. For example, the corner of carotid artery. So you know there are high possibility of having these, for example, injection of the pharyngeal artery, the ascending pharyngeal artery, not only give rise to the thoracovaginal artery and it's back to mandibular artery, filling up the internal carotid artery, while the injection of internal carotid also fill the mandibular artery and filling up the same thing. So be careful that some of your injection, this is the benefit of doing super selective injection. You see that you have ascending pharyngeal branch going front, and then mandibular artery filling internal carotid artery, while your usual neuromeningeal trunk coming down and filling up vertebral artery. So now you have the artery that are dangerous both to the internal carotid and to the vertebral artery. And for sure it's become larger when you have a sunking of the hypervascular tumor. This is nicely seen the IoT trunk that have the connection from this superior artery to this chicken leg of insult that can be seen, and at the back all the clival arteries can be coming part of the dangerous. We know that carotid artery is there, even we don't see it now, but in this we see a little bit vertebral artery as usual. For the injection of the ascending pharyngeal, be careful that you can definitely see the sunken disease can be the dural AV shunt. The dural AV shunt, especially at this area of the corona sinus, you see many clival branch going there, and that's why we don't recommend you to go transarterial, even if it looks to be reachable, because you will not really have hard time to see where are all the anastomosis. Some went into the vesical foramens and then go through this shunt. And my own case was this again, glomus tumor. You are having this nice musculospinal branch filling up this hypervascular glomus tumor. Immediately you see this going up, filling this internal carotid artery, and also at the back you see this usual system of hypoglossal filling up the vertebral artery. So make sure that the catheter is hooking up and down into musculospinal artery and give embolic material to still be safe. That could be also from the ascending pharyngeal or the meninges to the region, mostly to this type of foci labelli and Again, when you inject to see this type of meningeal artery, you definitely see vertebral artery and internal carotid artery at the same time. That is my first part. The second part